Hi, everybody, and welcome back to our next episode of Rewalk's Topics and Neuro Rehabilitation webcast. I'm Jill Butler, and today we'll be talking with Kelly McKenzie, a senior physical therapist at the Shirley Ryan Ability Lab, formerly known as the Rehab Institute of Chicago, and a board-certified clinical specialist in neurologic physical therapy. Kelly has worked on Shirley Ryan Ability Lab's inpatient spinal cord injury unit and as a gait specialist in the Legs and Walking Ability Lab, and she currently splits her time as an outpatient neurotherapist and as a research therapist in Dr. Arun Jayaraman's Center for Rehab Technologies and Outcomes Research, where she serves as a project coordinator for the non-invasive spinal stimulation study that is currently underway. Kelly's talk today will give our viewers an excellent overview of spinal cord stimulation with a focus on its use for improving locomotor function, and not only in patients with spinal cord injury, but also in stroke. This is an exciting and evolving field with the potential to provide us as clinicians a more complete understanding of and toolkit for treating our patients with neurologic-based locomotor deficits, I think. So Kelly, hi, it's great to talk with you today. I'm excited for you to be here.
Hi, thank you for having me.
Absolutely. So I'm a huge fan of the Shirley Ryan Ability Lab and all the groundbreaking work that you guys are always doing up there. So it's awesome to meet you. And to our viewers, I know that you'll love this one as well. It really gives you some food for thought and how you're currently thinking of your locomotor impairments. So let us know in the comments what ideas or questions pop up as you're watching. And don't forget to like and subscribe, of course. And with that, Kelly, I'll let you take things from here.
So as Jill said, my name is Kelly McKenzie. I'm a senior physical therapist at the Shirley Ryan Ability Lab. And I'm currently in a split role where I do part clinical work and part research work. And in the research lab, my primary role is serving as a project coordinator for a study we currently have underway. And it's involving the use of non-invasive spinal cord stimulation in patients with stroke. So today we're just going to talk about the mechanisms in the current literature that's out there regarding the use of spinal stimulation, both epidural and transcutaneous or non-invasive. And then I will give you an overview of the work that we are doing here at the Shirley Ryan Ability Lab using that technology. And then at the end, we'll kind of regroup and talk about like, what are the current clinical implications? How could we use this technology? What are the drawbacks? Where do we go from here? So spinal cord stimulation was actually initially first introduced with the first implantation occurring way back in 1967, which I found super interesting. I had no idea it had been around that long. And it was first used for patients with severe pain, but then its use was expanded after they improved motor function in a patient that had MS, and that kind of got us to where we are today with this technology. So currently in the US, it's approved by the FDA for patients with failed back surgery syndrome and complex regional pain syndrome. But it's also being studied in numerous other disorders, including numerous neurological disorders, including spinal cord injury, stroke, Parkinson's disease, and cerebral palsy. So there's a ton of literature out there. For time's sake today, and just because of where my expertise lies, we're just going to be reviewing what's out there regarding the use of spinal stimulation in persons with spinal cord injury, and then the work we're doing here at Shirley Ryan in persons with stroke. So what exactly is spinal cord stimulation? So basically, the epidural spinal cord stimulator consists of an electrode that is actually surgically implanted onto the epidural surface of the spinal cord, and it's connected to a pulse generator either directly or via wireless control. But the biggest thing I want you to take away from this as clinicians and as therapists is when we're stimulating, we're actually below the threshold for direct motor activation. So we're not stimulating so high that we're just directly activating the muscles themselves. We're below that threshold, but it's enough to trigger sensory triggered movements. So just very broad overview, generically speaking. So what happens is it lowers the activation threshold of locomotor neurons, which therefore makes it easier for proprioceptive and cutaneous signals to enable stepping. And the evidence suggests that the electrical fields spread toward the dorsal roots where the sensory afferents are. And because they have the lowest resistance, the large diameter proprioceptive fibers are the first neural structures that are actually recruited. So that recruitment then leads to activation of the motor neurons through the proprioceptive circuits, which just increases the overall excitability of the spinal cord. So essentially what we're trying to do, or what the thought is, or that's been found with this study, is the modulation then enhances the overall excitability of the spinal cord to residual descending input and then also the ascending sensory input. So this is not at all a complete list of all the studies that are currently out there regarding the use of epidural spinal cord stimulation in persons with motor complete spinal cord injury, but these are some of the really big ones that have been out there to improve walking function, and then there's a couple of really interesting ones also out there on improving upper extremity function. And so you can see they're kind of all very different with their dosage and approach. And it's like, so this one here, the LU 2016 study, they involved 20 training sessions. But then if you look over at the Harkema and Angeli papers, they did up to 278 training sessions for more than a year. So just a big difference with dosage there. But what I found really interesting, and these papers were published in Nature Medicine and the New England Journal of Medicine, so super groundbreaking work, is that after implantation and with training and after tuning the stimulation appropriately for the individuals, they were able to achieve independent overground walking or overground walking with only intermittent assistance in people with motor complete spinal cord injuries, which I think is super exciting because we've never been able to achieve that before. So hopefully, as this technology develops, we can use this to help persons with motor complete spinal cord injury be able to regain walking function and upper extremity function that they otherwise wouldn't have had with the stimulation. But, kind of a downside here is if you look, you see n equals 4, n equals 1, just small sample sizes. So something to move forward with is kind of the generalizability and like, how do we make this more applicable to a broader population? So this video is actually from the Gill 2018 paper. And this is from a patient who's a 26-year-old male, and he had a T6 Asia A spinal cord injury, a chronic injury. And in all the videos that you see him walking, the stimulator is turned on. And so you can see that at the very beginning, he's requiring body weight support, assist for advancement, and stance control. Then, kind of in the middle of his training, the therapist is still assisting at his hips, but no longer requiring body weight support. She kind of helped him get going most of those first couple steps, but then otherwise she's pretty much just helping block his knees there and with stance control. And then you see here at the end, which is what is so exciting, is the therapist is now providing light assistance at his hips, but otherwise no longer requiring assistance at the lower extremities. So again, this is with the stimulator turned on, but this is a person with an otherwise motor complete spinal cord injury that otherwise would not have been able to perform these stepping functions. So these are amazing results, but at the same time, surgery comes with risks, and anytime you're implanting an external device, that could lead to some issues down the road. So that's what then led to looking at the use of non-invasive or transcutaneous spinal cord stimulation, where just regular hydrogel electrodes are placed over the neck and back, and then also over the ASIS for a ground electrode. And usually it's placed at the thoracolumbar junction if you're targeting walking function. And then more recently, so that in the Dr. Yuri Gerasimenko came out with this new very specific waveform that doesn't elicit pain, even when you're at high intensities that are required to reach the spinal networks. And that is a biphasic waveform that comes with a carrier frequency. So usually before we were limited in this method, because in order to reach the spinal cord, you have to use fairly high intensities, and patients just weren't able to tolerate that from a pain standpoint. And so now this biphasic waveform leads to either painless or very minimal pain during the treatment sessions. So again, this is kind of just a summary of some of the big articles that are out there regarding the use of transcutaneous spinal cord stimulation in motor complete spinal cord injury. And there's also a whole nother set of studies in patients with motor incomplete spinal cord injury. But what I found some interesting here is one thing they did in the GAD 2017 paper is they combined the use of the transcutaneous spinal cord stimulation with robotic gait training And I thought that was a really neat combination, or kind of collaboration with two different technologies of how can we use those together. And then they also used some pharmaceuticals in that study. And they found that the use of the drug and the stimulation together led to the lowest levels of robotic assistance. Then what I also found really interesting in the Gerasimenko papers is they were able to achieve a stepping pattern using the stimulation, but when the patient wasn't giving any form of voluntary effort. So the stimulation alone can trigger those stepping movements, but then also they saw an increase in the LMES scores of the patients, even without the stimulation on. So that shows that there was some sort of carryover effect that was occurring after the treatment sessions. And then you can see here, I also found these results really interesting, is the major increase in grip strength that they know the patients had the stimulation on, but again, also when they tested them, even with the stimulation off. So some sort of carryover effect is happening, something is happening in those neural networks that's leading to a change after training, even when the stimulation is not present. So how are we using this stimulation here at the Shirley Ryan Ability Lab and applying the transcutaneous spinal cord stimulation and using it to a new patient population? And we are actually studying the use of this technology in persons with stroke. You're probably thinking, Kelly, why on earth are you stimulating the spinal cord? These people had a stroke, which affected their brain. This makes no sense. And I thought that too when I joined the lab. I was like, you want me to do what? So we first started with a study of like, what is even happening at the level of the spinal cord in persons with stroke? And there's a little bit out there in the literature, but not a lot. And most of it is actually in animal models. So we just wanted to see, so we were doing the spinal motor evoked potentials, the testing at baseline, but I was like, we don't even know what normal is. So let's just first start with like, what is normal? How does individuals with stroke compare to individuals who haven't had a stroke? So we looked at 10 persons who've had a stroke, 10 healthy age-matched controls, and then also 10 young healthy controls. We had them come in for just a single day assessment, and we stimulated the spinal cord with non-invasive spinal cord stimulation between L1 and L2. And then we measured their resting motor threshold and the latency of their response. So the first thing we looked at was resting motor threshold, and that's the lowest level of stimulation that is necessary to activate the motor pools without any form of voluntary activation. So the earliest we can see activation are the lowest intensity. And in this graph here, you'll see that the pink line represents our young healthy group, the green line represents our age-matched control group, while the blue line represents the stroke survivors. On the x-axis, you have stimulation intensity, and then on the y-axis, you have the MEP amplitude. And this graph is just a visual. It's data from just one person, but I think visually it's just the best way to represent what are we even talking about with these results. So we're looking at what is the intensity required to see a response in the lower extremity motor pools without the subject doing anything. And so then this is the group data and the results that we found. And on this graph, you're going to see that the x-axis corresponds to what group we're talking about, so young healthy, age-matched healthy, or stroke, and then also their size. So we group together paretic is the same as non-dominant, and then we said non-paretic, we grouped with the dominant side of our healthy controls. And what I want you to note here is that the stroke group had significantly higher resting motor thresholds in both the TA and medial gastroc muscles as compared to, especially the young healthy, but even compared to their age-matched controls. So that tells us that this change was not simply due to aging, that something happened, after the stroke that caused secondary degeneration of the spinal cord, which therefore, influenced their connectivity and excitability of those spinal motor neuron pools. So next we looked at latency, and so that's actually a measure of the signal propagation time. So once we send the stimulation signal, how long does it take for their muscle to respond? So this data is also just for representative from one individual, but just to give you a visual of what we're talking about. And this is how we measure latency. And then what I want you to notice here is just the difference between the paretic and the non-paretic sides. So here's the stimulation, that the input that they're receiving, and then over here is how long you see it takes for them to get a response. And you can see there's a side-to-side difference that we noticed in our stroke survivors. And then again, this is the group data, so comparing the stroke survivors to the young healthy controls and the age-matched healthy controls. The x-axis on this graph corresponds to the TA muscle on the left and the MG muscle on the right, and then the y-axis corresponds to latency as measured in milliseconds. And what we noticed again is that the stroke survivors had a significant delay in their latency for activation of the TA muscle compared to age-matched and healthy controls. And then they also had an additional 15% delay in their paretic versus their non-paretic limb. So this means that they have delayed conduction time in the axons that are originating in the spinal cord compared to healthy controls, and an additional delay in the paretic limb versus the non-paretic limb. So this showed us that even though the lesion occurred in the brain, something is happening in the spinal cord where it's shutting down or kind of down regulating, and exactly why, I can't say, but was it just because it's receiving less input? Was it due to the, did it happen initially with the lesion itself? So these were chronic stroke survivors, so something in the future we need to look at as persons with acute stroke. But then what it just told me is, so on top of the cortical damage, you're now having the secondary degeneration in the spinal cord. So it's kind of like two things happening at once that we need to address. So after we saw this, we were encouraged to move forward with the actual clinical trial portion of our study, and where we're looking at the use of transcutaneous spinal cord stimulation combined with gait training and how that influences outcomes as opposed to just gait training alone. And thus far, we've completed 4 participants in each group. And what we did here is, after we completed the stimulation group, is we recruited matched controls. So we wanted to make sure at baseline, the 2 groups were pretty similar. So we matched the control group participants to the stimulation participants on age, time since stroke, and gait speed. And here's some demographic data of kind of where we started and the background. Then what we did is we did testing sessions before and after, as you normally would, a pre and post testing. And then we did training sessions 3 times a week for 8 weeks, so 24 gait training sessions total. And during those gait training sessions, they received 45 minutes of actual gait training, plus a little bit of extra time for setup and breakdown. And the primary outcomes that we were looking at here was we wanted to see if the stimulation had an impact on their spatial temporal gait symmetry. We wanted to go beyond the typical function or typical measures that you use of the 10-meter walk test for gait speed and the 6-minute walk test for kind of walking or cardiovascular endurance, because we wanted to see if this was actually influencing how they were able to move their paretic limb, and are they able to make it more similar to their non-paretic limb. So what change are we making? Hopefully, are we making an actual neuroplastic change rather than just a functional change? And then as far as training goes, so we spent 15 minutes in what is called gravity eliminated locomotion or sideline locomotion, and I have a video for you guys of that. And that was modeled off of the spinal cord injury studies that have mainly been done by Dr. Gerasimenko. And then we did 25 minutes of treadmill training with visual feedback on the C-mill treadmill, and then we did 5 minutes of overground training even immediately after the treadmill training to promote a functional carryover, and just seeing, all the feedback that we provided with the session, was that making any difference when we actually transitioned to overground. So here's a video of the sideline training. You can see that the participant is laying on their non-paretic side so that their paretic limb is on top. And they're then suspended in this device, which essentially allows them to practice a stepping motion without being in a loaded position where they're worried that they're going to fall, or they may have increased pain when they're in weight bearing. And so theoretically, it allows them to actually practice that symmetrical stepping movement. So then this is just a video of the C-mill treadmill for those of you who are not familiar with it. So basically, this force platform is in the bottom of the treadmill, the belt of the treadmill, and the participant on the screen in front of them is able to get step-by-step feedback on how they're performing as far as step length goes. So rather than the therapist or me just chiming in their ear the whole time of take a longer step, it actually gives them concrete feedback of how they're doing. So most of the time we would give them an actual target of like, I want your step length to be 1.2, or, and people did really well with that, as they could see, for themselves how their performance was. And then these are a couple videos of one of our participants and how he performed. So this is his baseline testing. And during all the testing sessions, we tested them without stimulation. So we wanted to see if there's no stimulation present, how is that impacting their performance? So baseline testing without stimulation, this is his self-selected velocity. And this participant is a 67-year-old male who had a hemorrhagic stroke in 2013. And you can see that he has a shortened step length with the right lower extremity, and he rarely ever even achieves a positive step length. And then he also has a really short stance time on the left lower extremity with a super slow cadence, and a fair amount of lateral trunk compensations just to advance his limb. Then after he completed the 24 training sessions, this is again him walking at his self-selected velocity without stimulation. So the biggest thing you notice here is just improved velocity, but also he's getting a positive step length pretty consistently there, and also improved stance time. And you can see a little bit of improvement there in actual hip and knee flexion rather than just using compensations to advance his limb. So unfortunately, we're still in the publication stage right now. We're submitting, refining our papers. So I can't show you the data in graphical form, but I can tell you the results and what we're seeing. So symmetry was our primary outcome. And what we noted was the STIM group had greater improvements than the matched controls for both swing time symmetry and step length symmetry, which is great. The primary outcome we wanted to see, is this actually influencing how they move and improving it? But then we also very much care about function. So we still tested the 10-meter walk test, and every single STIM group participant met the MCID for improvements, whereas none of the control group participants met the MCID. And then we also saw a statistical significance between the two groups, which is exciting. And then in the 6-minute walk test, all of these STIM group participants again met the MCID, whereas only one participant in the control group met the MCID for 6-minute walk test changes. And what's interesting to note, and I forgot to mention this earlier, is as we were training, we emphasized symmetry first before progressing speed. So, which is different than what I often do in my clinical practice. So I struggled with that a little bit. But we first wanted the subjects to demonstrate to us, using the female or even just overgone with my visual assessment or a therapist visual assessment, is we wanted to see, improved stance time on the paretic limb, a positive step length, all those things before we were cueing them to walk faster. So what is interesting is we were emphasizing symmetry prior to speed, but yet fast velocity gait speed still improved and showed significant improvement. So how do we kind of take all this information from, what is out there in the literature and what we're currently investigating and apply it to our populations, or, where do we go from here? So I think one of the biggest things is just appropriate patient selection. And that's something that we've noticed here is, some people are great responders to the stimulation, some are not. Some simply just cannot tolerate, if you're using the non-invasive stimulation, even with the biphasic waveform, they still don't let you go high enough to where you can actually see a change, and even though you're still at the sub-threshold intensities. And then on top of that, I think there's some really great research out there. I was reading some more papers that they're doing more studies in persons with Parkinson's disease and cerebral palsy. So it's just kind of, and what this has taught me with doing our study in people with stroke is thinking outside the box. So even though, like I said, the lesion was in the brain stimulating spinal cord, we're seeing some changes. So what other populations can we apply this to, and using that down the road? But then also considering safety. Like I said, with epidural spinal cord stimulation, there are some risks. Primary being, there's a risk of infection just because you're implanting an external device into the body, and especially in a very sensitive area. So the papers you read, it tells you there's anywhere from 8 to 75% complication rate, which isn't super helpful. So just making sure, that, if you have a patient who's pursuing this, that whatever location they're going to is, doing it in a safe manner. And then also feasibility. So for epidural, it's also, much more harder to do than non-invasive, you know, there's a full surgery and, you know, everything that's involved there, as opposed to non-invasive. You simply just need hydrogel electrodes, like I said, and you place, you know, palpate, place them over the correct locations, and the setup takes about 10 minutes. So it's pretty quick. And then, you know, we don't know enough at this point, but I think down the road, this is something that we can just integrate into our clinical practice if we find that, you know, it is valuable and efficacious, and we can just implement it into training sessions that we're already doing. But then we also have to figure out dosage. If you remember back to those graphs that I showed, you know, anywhere from 20 to 278 training sessions. So that's a huge range. So how many training sessions do our patients need to actually see a change with this technology? And we don't know that yet. But we do know that right now, you know, insurance is pretty limited for our folks that are in the outpatient setting. So we need to make sure that we are creating a meaningful change and we're doing it in a reasonable time frame. And then also training parameters. We still have to figure out, you know, something we struggled with and we're still trying to figure out is what stimulation intensity do we choose for a given individual? And we noticed there's an individual to individual difference. Sometimes there's a day-to-day difference. Sometimes, you know, a stimulation intensity that looked really great with our participants one day didn't look so great the next day. And then how do you address that in figuring out what is best for an individual, and how do you optimize those training or those stimulation parameters? And then also, what training methods do you use? Are we correct in doing the sideline training, or, you know, doing treadmill training or overground? Like, how do we best integrate this technology into our training approach? And then, you know, one of the biggest questions that I think is kind of happening kind of throughout rehab right now is true neuromodulation taking place, and, you know, the key word of neuroplasticity, or are we just making people more functional and teaching them to compensate in a really, you know, effective manner? And I don't think we know that answer yet. So I think that's something that we still need to pursue, is, are we actually creating, you know, true changes to their nervous system, or are we teaching them to get really good at compensating? And we don't know. So what I found interesting, and this is mentioned in a couple different papers, is maybe what we need to do is a combination training approach. So maybe it's not spinal cord stimulation alone that's going to be, you know, the magic pill or whatever you want to think of. So maybe it needs to be spinal cord stimulation, some sort of drug intervention. So task-specific repetitive training, maybe muscle stimulation needs to be in there. Maybe we need to be using robotics to promote good kinematics. And I don't think we know yet. And I think there was the case study done by GAD that I mentioned earlier that combines spinal cord stimulation with pharmaceuticals, with robotics gait training. So I think maybe we need some more studies like that in the future, because I don't think one single thing is going to be the end all be all. So maybe we need to combine all these different approaches if we want to see the best outcomes for our patients down the road. So that's all I have for you guys today. Thank you for your time. Here's my email address. Feel free to email or contact me at any time if you have any questions or just want to discuss things further. And then a whole bunch of references for you. There's a lot of interesting work happening out there, and I really encourage you to read it.
Thanks a lot, Kelly. Those are some really exciting and novel ideas that you and your team are working on over there. I'm so excited to see what the future holds for spinal stimulation's overall impact on the neuro rehab world. Before we go, I have a few questions prepared for you. So those results coming out of the motor complete SCI studies, those are wild. I'm wondering what you think about them, and do you see this technology as something that will be utilized sort of short term as a treatment intervention, or something more so to help with like long-term mobility for people?
So Epidural is by no means my area of expertise, simply just the literature that I've reviewed for my study and, you know, different presentations and personal interests. But I do think for the most part, it'll be a long-term mobility aid. But hopefully in the future, I guess I'm wondering if we implant earlier, if we can, you know, retrain the spinal cord before that chronic degeneration takes place. You know, maybe it could be a treatment intervention down the road. I don't know. Or, you know, maybe in persons with incomplete injury, you know, maybe again, we could use it more as a training approach. But I think right now, or, you know, in the near future, for persons with motor complete spinal cord injury, it'll be more of like a long-term mobility aid.
Okay, makes sense. Awesome. So in treating stroke, let's shift over to that and the work that you guys are doing at the lab there at Shirley Ryan. So in stroke in general, we've been hearing so much lately about success achieving neuroplastic changes through maximizing dosing and intensity. But in terms of thinking about secondary impairments at the level of the spinal cord, I find it so interesting that there could be sort of a missing link in how we're thinking of treatment planning in this population. So does this concept of the spinal cord impairment being secondary to the effects of the cortical lesion relate to your guys' study design on focusing primarily on quality of the motion? Can you speak a little bit more between those?
Yeah, so I mean, like I said, in my clinical practice, I am very much emphasizing intensity and speed and dosage. And, you know, I'm not entirely usually really refining kinematics. I just want the person moving. But then in this study, and this is something that our full study team here, especially Dr. Jayaraman, really helped guide me and the other members of the study team, is we know that high dosage, high intensity step training is great for stroke survivors, and that can lead to amazing functional changes. But we wanted to see, you know, for this technology in particular, is are we making any change with how they move? And we chose that simply because we can measure that easily in a clinical setting. We are also doing spinal MEP testing, like I said, pre and post. So the reason we chose symmetry is because we didn't want kind of, you know, like to overshadow, you know, any of the effects that we were seeing from the stimulation from training at a high intensity or a high dose, because we know that works. And so we wanted to see, you know, the stimulation alone, what impact does that have? I don't know if that answers your question.
Yeah, it absolutely does.
Yeah.
That's very thoughtful way to think of it, for sure. All right, I have one more for you. So with symmetry and movement quality then as the primary focus of the study, can you elaborate a little bit more on any and all tactics that your team utilized to help your subjects achieve that goal?
So when they were in a sideline position, we did provide hands-on assist, but we tried not to. But sometimes the first couple sessions, people are like, you want me to walk on my side? I don't know what you're talking about.
Right. Yep.
So there was, you know, a little bit of hands-on assist if needed. And then I think the video maybe just didn't show it very well. We actually had a camera hanging overhead, and that was actually how I got the video of the person stepping, but then we projected that onto a TV screen in front of the participant, so then they could see, okay, here's how my leg is actually moving. Some people also preferred a mirror in front of them so they could see it from that viewpoint, but most people liked the overhead view so they could actually see the arc of their hip and knee, and then providing verbal cueing as needed throughout. And then when we transitioned to the treadmill training, like I showed you with the CML, that gave them step-by-step feedback, you know, on their, you know, their performance and how they were doing. So we had that screen running at all times. And it not only gave them step lengths, but it gave them a symmetry measure. And then it also has a diagram at the top that shows how much weight they're putting on each side, and it's an equal distribution. So they were able to see that. And then we were also providing verbal cueing there. Once they were on the treadmill, we were no longer providing physical assistance, and we did not use body weight support for this portion. Sometimes if the person, you know, was a high fall risk, we would have a harness on, but it was only as a catch system. And then once we were over ground, this is where I, you know, tried to think back to my motor learning days in PT school. I tried not to say too much. I wanted to see, you know, what have they learned from the last 40 minutes of training on their own, but occasionally I would give some intermittent verbal cues if needed. And during that training, we let the person use their personal orthotic device throughout. But we tried, as best we could, and if I'm remembering right, all our participants trained without an assistive device because we wanted to promote bilateral like weight bearing versus really leaning into the cane or the walker, you know, whatever it is that they're using. So we allowed them to use their orthotic, but we tried to avoid assistive devices in order to promote weight bearing through those legs.
Awesome. It makes a lot of sense. Thank you so much. And thanks in general for a great talk. Thank you for your time. It was great having you.
Thank you for having me. This was fun.
And to our viewers, we hope that you've been finding these talks interesting and helpful. Don't forget to reach out in the comments section if Kelly's talk sparked any questions or ideas. And please also make sure to like and subscribe to this video using the buttons below. We hope you tune in again with us next time.